Pain concerns, general health concerns, bring them on. Dr. Lou's here to talk to you over the next hour, and we'll get to a bunch of different stuff. Info at paincarecanada.com through email, and a reminder to call the clinic at that free consultation happening. 1-855-55-Dr. Lou, DRLOU is the number. Would love to hear from you today. We always start out with some week that was, some cases, some clinician stuff that's come through the clinic. What's going on, pal?
Yeah, there was actually an interesting case this week that I had. It's quite rare. I'll go through the full case, but it is something that is very rare. But I did think it would be a good idea to share this. This patient had a disc herniation in her neck. I believe it was about 4 or 5 years ago. And she eventually had to end up having surgery for this disc herniation in her neck just to help with the symptoms. Years later, in the winter, during this winter and in the spring, she starts developing intense pain in her left arm. One day she actually is sitting there and all of a sudden her left arm just completely swells, and intense pain, and then goes away. Still getting intense pain on that side. I believe a month later, same thing happens to her left foot, where it just all of a sudden swells out of nowhere, and she has intense pain. And so she comes to see me because she doesn't know what's going on and is trying to look for, at least a direction of what could this be. And so there's a couple things that it could be. One of the things, she's also a smoker. So anytime you have a smoker that gets weird symptoms like that, there's something called a paraneoplastic syndrome that can happen with certain types of lung cancers that can lead to all different types of weird symptoms. So in someone who's a smoker, always something you have to consider anytime you hear weird symptoms. We listened to her lungs. It sounded fine, which was good. The other thing you want to consider now is neurological. There's something called complex regional pain syndrome. Mm-hmm. It's kind of, and I've talked about, I've used the term before, wastebasket diagnosis, kind of when you've ruled everything else out that has good objective markers and there's nothing else, then you can use some of these wastebasket terms. Complex regional pain syndrome is kind of like that. What complex regional pain syndrome is that usually it's in response to some type of trauma to the nervous system, specifically the spinal cord or the brain. And in this case, like this patient had surgery. And I tried to explain to her, and this was the point that I really wanted to get across for people listening today, that I think is the more important thing to highlight, is that surgery at the end of the day is controlled trauma. Right? At the end of the day, your body doesn't know the difference between trauma that's, by accident or trauma that's induced by a surgeon. Because even when you look at things like frozen shoulder, very common after trauma, but a lot of people have surgery for something else in their shoulder and then develop frozen shoulder. And again, when you look at it, a predisposing factor is the trauma component. And it is important to note that anyone going for surgery is trauma. It's
invasive. You're getting
it's invasive. It is in a controlled environment. It's by professionals, but at the end of the day, it is trauma to your body. That's something that I really, really want to get across. And I'm not suggesting that you don't do surgery. I'm just suggesting that you're aware of this, because trauma does predispose to certain types of other pathologies down the road, such as what we're talking about here with the complex regional pain syndrome. Now, in this particular patient's case, can we absolutely say that her spine surgery led to this? No. But again, with all of these wastebasket type of terms, we're not, looking for a definitive answer. We're just looking at what are the common things that can lead to this. And so with complex regional pain syndrome, very, very common to have exactly what she's experiencing, which is unexplained extreme pain, with periods of extreme swelling that just go away. And she showed me the pictures. This wasn't just, and that was really important. I thought that was a really good thing that she did. A lot of people will see something and then go to a healthcare practitioner and they'll just try to describe it. Yes, this looked swollen. With today's world, taking pictures is not a bad idea, because there's a lot of people that I ask, and with a knee complaint, has it been swollen? Yeah, it's been swollen, and then you look at it and it's not swollen at all. So what someone may think is swollen may not actually be swollen. But this lady, this patient was actually very, very smart, took pictures of what was going on. And it was great because I was able to look at it and say, yeah, this is pretty consistent with what's going on. So now, again, in this type of case, too early to say what the outcome is going to be. But what based on all the signs and symptoms that she was presenting with, it did seem pretty textbook for complex regional pain syndrome. But again, it being that wastebasket kind of diagnosis, we have to rule out everything else before we can just jump to that.
And if it is, what's the treatment?
And that's a great question. And there's no the issue with complex regional pain syndrome is it's all related to the sympathetic nervous system just being extremely overactive. So there's a lot of things, there's things like modifying the diet, medications, therapy, neuromodulation, psychological intervention. It kind of
it's a multi-pronged thing.
Yeah, it's the same type of idea as chronic pain. How do you treat chronic pain? There's no one answer. It's multifactorial, multifaceted. You got to attack it from every angle. And again, it's one of those things that you're not going to quote unquote cure, but you are going to have to learn how to manage so that day to day you can live with this issue.
We'll take a quick break. Your phone lines are open. You're feeling pain. You have questions. Bring them on for the next hour. Dr. Lou is here to answer them. 416-870-6400 *640. On your cell, just getting started and revved up. The Dr. Payne Show, Talk Radio, AM 640. Tom in Whitby. Good afternoon.
Good afternoon, guys.
What's going on, Tom?
I have a bulge disc at C5, C6 in the neck.
Okay.
And I have I have some sensory radiculopathy in my right arm.
Right.
As a result, but no muscle weakness, occasional cramp, but that's about it.
Okay.
Nothing to justify, apparently. I still to see the neurologist at Western for a follow-up after a CT scan, but no justification for an operation, given it's just sensory. But it's progressing into a bit of an uncomfortable, 5 to 6 on the pain scale in the neck area.
Right.
It's like a constant headache, sort of referring to the top of my head, just it's always there kind of thing. I'm on Celebrex. And he put me on, my family doctor put me on Lyrica.
Okay.
Which I came off with just some pretty bad side effects, including, gaining 30 pounds in 2 weeks. And
jeez, really?
What?
And,
wow.
And itchy extremities. I could not get enough food. Like, it just stops your, the sensory, the sense of getting full. So you just eat too much. So anyway, are there any appropriate or other drugs that you can think of that, because I'm going to have to live with this.
Well, so Tom, how old are you?
I'm 50.
50. And have you done any therapy for your neck?
The neurologist recommended against physiotherapy for it.
Why is that?
And chiropractic.
Okay, why did he say?
He just said he called it a room full of useless modalities. Like, it wouldn't help. And actually, I did do physical therapy for a while.
Yeah.
And it didn't help. The stretches, the medial stretch, and, the various stretches for that area. And I tried traction, and all it does is inflame it.
Right. Yeah, I mean, again, it's very hard for me to, comment very specifically over the radio, but I would be very, very surprised that if it's a case that therapy couldn't help at all. Do I agree that sometimes certain places are not the best place to be doing therapy? Yeah, sure. But I think in any instance like this with a disc herniation, if it's treated right from a physical perspective, is it going to help 100%? Maybe not, but it will be part of the overall picture of getting better. Most disc herniations are not things you have to live with forever. You may have to manage the symptoms as you go on, but they do have a natural history that they should get significantly better, even if you did nothing within 18 months. And again, that's, me assuming a lot of things here because I'd have to see an MRI to kind of look at exactly where it is. But there's, McKenzie protocol for the neck herniations, disc herniations that can really be beneficial. The medication, all it's really going to do is block your perception of the pain. It's not going to solve any issue.
Yes, please.
Sorry?
Yes, please.
Yeah, and that's exactly, and assuming that even works, right? Because,
Right.
you have to get the right source of the pain. So, I don't think, based on what I'm hearing, that's necessarily the best approach that you're on. I think if you're going somewhere that's the right place, the right treatment, the right type of physical treatment is going to be very, very beneficial towards getting better. How long has this been going on?
We're approaching 12 months now.
12 months, okay. And how did it originally start?
There was no immediately obvious cause. Like I didn't fall. There was no car accident. There was nothing. I had previous, decades ago, a car accident when I was younger, but it was fairly minor. And then I was ditched on the beach head first by when I was body surfing, which caused a lot of pain in my neck at the time when I was a teenager. But I mean, not asymptomatic since then until 50. I think the warranty just ran out. Kind of.
Right.
Yeah, right.
How many times have you seen that neurologist? Like, did you see him early on in this, or have you seen him or her more recently?
I was referred to him. There was quite a long waiting period. I did get an MRI done. He reviewed it, and he said it's the worst MRI he's seen in 20 years.
Wow.
It was a sort of a third party. It wasn't done at a hospital.
Okay, yeah.
The third-party company, he said, and I said, it looks modern. The equipment looks modern. I don't understand it. He says, well, they're not spinning the dials right because it's blurry. It's crappy MRI. So he's called for a CT scan to see, and even the diagnosis missed some signal change on C5, the actual vertebrae. So it looks a little white.
Okay.
So he says, I want to see what that's about. And, so we're going forward. But it's just slow and painful.
Well, yeah. I mean, in all honesty, I would recommend a second opinion, right? Because I don't necessarily think that sounds like the best approach that you may be on. I think there's always other options that can be done. And I've always said anytime it's a physical problem, having a physical intervention, if done right, and that's a very important thing. And sometimes I do know certain specialists and surgeons, because they don't know exactly who they should or should not trust in these things, will just kind of give the recommendation that you've been given. But I think it's a bit of a disservice, because I think there's some very, very good ways to physically treat that type of a problem, no matter how bad it is, that can at the very least help. Right? Is it going to be 100%? No, but even if it can help you, and I think you're looking for just things to overall be getting better slowly versus getting worse slowly, because that's my impression from our conversation, is that it seems to be getting worse.
It does.
Yeah. Tom, if you want to have a discussion, you want a second opinion, I'm happy to give you that. If you have all those relevant, imaging studies, I'd love to review them and kind of see, and again, correlating them with the clinical presentation, which is very, very important. You can't just stop at imaging. You have to make sure that the imaging matches up with what you're seeing in the office.
Tom, to follow up, 1-855-55-DRLU, 1-855-55-Dr. Lou, and info@paincarecanada.com. A room full of useless modalities. Bad advice. Good band name,
Some places are, but, I don't think that... Yeah, that's funny.
It's a decent band name. Thanks, Doctor. We'll get to more of your phone calls. 416-870-6400, star 640 on cell. Dr. Payne Show continues. Talk Radio, AM 640. Phone lines are wide open. Give us a call. You have pain concerns. You're feeling something. You have no satisfaction with your current medical team. Give Dr. Lou a call here at the station and maybe get some answers between now and 1 o'clock. Leo, how are you, Leo?
Hi, how are you?
Good, sir. What's happening with you?
I had a very bad car accident 4 years ago. I have all my discs in my neck are bulging. I have 2 entrapments in my neck and 1 entrapment in my back. I've been to about 9 doctors they sent me to for the car accident, and every one of them said there's too much damage to even think about an operation. So I did therapy twice. Now they cut me off therapy. Therapy was starting to help. They said, no, you maxed out your therapy. I don't know what to do now. The pain is so bad that there's days I don't want to be here no more.
Right. Do you have a lawyer that's dealing with this? Yeah. So, I mean, it is unfortunate, because the way, the accident benefit world works in Ontario is something called the minor injury guideline. And if they deem a person's injury to be in the minor injury, well, then there's a cap on how much money will be spent on therapy. And then, if you're deemed outside of that minor injury, there's a larger amount of money dictated for that treatment. That doesn't mean that you can't appeal those things, and that has to be a combination of effort between whoever the legal representation is and the treating professionals to make the case that, this person does need more therapy based on the injuries that they sustained. The harder thing always to prove in these types of cases, Leo, is those disc herniations that you have in your neck. It's oftentimes very hard to prove, are they the result of the car accident? Because in likelihood, you probably, if you never had neck complaints, you would have had no previous MRIs or anything like that to compare it to. And, what I can tell you is when you look at the research, a lot of people have disc herniations that are asymptomatic. And the insurance companies know this, which is why they will argue, try to argue against that type of stuff. So it does have to be, again, an effort between the legal representation and the treating professionals to continue putting in treatment plans, for the services that seem to be helping for you, and seeing if the insurance company will approve them. Now, the insurance company will then likely send you to an independent assessment from someone that they've hired to deem if these recommendations follow suit with what they're seeing. And so the process can be pretty lengthy. So, but in the absence of that, I mean, you always have the option to pay for your own treatments, or sometimes what lawyers will do is they'll protect the file where they let a clinic do the treatment, but they know that you have a strong case and they protect the file. So those are some of the other options that you may want to discuss with your legal team.
Okay, because see, I unfortunately I had an operation on my lower back in 2004. That's creating some problems. Mm-hmm. But I had MRIs on my neck and my back before this accident, and there was no problem in my neck before. So the neck, they know it is caused by the accident.
Well, then those. So yeah, and if you have something like that, that does support your case that yes, this accident caused these things because they weren't there before. So that's very good, strong evidence. Which again, in my experience with the lawyers that I've dealt with on accidents like this, if the lawyers believe that there's a strong case, and even in the absence of the insurer wanting to pay for more treatment, they'll often protect the file and keep getting treatment just because they feel that, number one, they want to help get you better, and number two, they want to help build your case against the insurance company.
It's just ridiculous, though. I mean, every time I turn around, I even had my doctor give them a note saying this man needs therapy very badly. I can barely move my neck, and the migraines are so bad that I'm in my house in a dark room, almost 5 days out of 7, in the room all day, dark room.
Right. Yeah. No, I understand. Unfortunately, I've had a lot of patients like that are involved in motor vehicle accidents or slip and falls or workplace injuries. And, anytime you're working with a third-party payer like that, it becomes an issue when it comes down to payment and things like that and how much treatment they should be paying for, which, it does, I think, hinder the overall objective, which is just simply to get better when you have to worry about all those other things. But again, it's a complicated case, and if you have a legal team, you have a place where you're getting therapy, they need to kind of work together to build a case for the insurance company to justify you getting more treatment.
Well, they're trying. Trust me, my lawyers have been fighting, and they've been turning the lawyers down left and right too.
Yeah, good. That's good, and that's really all that you can do. But in the meantime, like I said, you do always have the option of paying for treatment if you have to, if you really need it. So. Yeah.
Appreciate the call, Leo, for you as well. 416-870-6400 *640 on cell. Would love to hear from you over the next half hour of the Dr. Payne Show, Talk Radio, AM 640. William, good afternoon.
Hello, sir. I don't know if I'm quite qualified for all of this, but perhaps
I'm sure you are.
Interesting conversation.
Sure.
I'd like to know the difference between mental illness and post-concussion syndrome, and if psychiatrists know these things.
Yeah, they would know these things. So when you look at mental illness is more of a psychological problem that's related to thought patterns and behavioral things, whereas a head injury, like a concussion, is when there's actual movement of the brain within the skull. And so there's something called coop-countercoop, where the brain actually hits different parts of the skull on the inside. And so it's that, I guess you could call it bruising, that leads to those types of head injuries. So they're two very, very different things. One is very much a physical type of trauma to the brain, and the other one is not necessarily a physical trauma, but more of a, behavioral, psychological, psychosocial trauma, I guess maybe is a good word for that too, but two very distinct things and treated in two very, very different ways.
Okay. Now, so when the brain can go back into position, because I was a victim of an assault, and I've got a whole diagnosis from the hospital of what happens and what does not happen, and it's been about a year now, and I've been to a neurologist, and he says it's all gone, and I agree, it's all gone. Mm-hmm. It took a year to go away, and now everything has moved back into place, and just some skeletal injuries, and then they're improving as well. Is that correct?
Yeah, so when you look at the actual movement of the skull the brain within the skull, it happens very quickly. It goes back to its quote-unquote normal position almost instantaneously. Yeah. But that doesn't mean that there's no effect to the areas that were contacted. And so, the other thing about concussion is it's not really something that's actually picked up on imaging. There's nothing that you actually see. It's more a constellation of symptoms that a person will present with. And, if those symptoms improve and go fully away, then you can say that the person's concussion is gone. But if the symptoms still persist, well, then the concussive syndrome it could be ongoing. So if the symptoms that you were having following your assault are now gone, then that sounds like your concussion has resolved.
Okay, and after concussion goes away, you're back to normal, because Sidney Crosby, Pittsburgh Penguins, he's had 5 concussions,
right?
And he's well paid, and they're not going to put him back on the ice unless he's 100%. So these things really do go away, right?
They do go away, but like anything in the body, once you sustain an injury, whatever that injury is, you are now more likely to re-experience that injury compared to someone who's never experienced it. And that's the exact reason why you said Sidney Crosby has had 5, because every time he sustains a new concussion, he's now more likely to keep sustaining concussions. Okay. So that's the same thing with you. You are now likely, if you have a head injury, to sustain another concussion. The whole hope is that you're not going to have any more head injuries, and so in the absence of any more trauma, then you should be fine. Yeah, for sure.
Now, I'd like to put this across to you, because this will be helpful to other people too, not just to me.
Yep.
I was diagnosed with mental illness by. I just tell you this. I spent 60 days in prison for emailing Bible scriptures to a police officer, which is plain stupidity, but that's what happened. And the nurse there said I had mental illness, but it was not. It's post-concussion syndrome. And I did some research, and Professor Arfield from London, from Western University in London, says that the mental illness test for Ontario is literally useless. And I look back at the questions they asked, and I was assessed wrongfully and put through a lot of garbage for nothing. And I don't know what I can do about that. Probably nothing. I'm very happy that I'm healthy again. But I just thought I'd put that across. Maybe it's helpful for other people. And one more comment. I find it very convenient that in the definition of psychotic, if you think you're being followed by people, you're automatically psychotic without anyone doing any investigation on the issue. And you have to investigate these things. You just can't sit there and judge from a convenient.
Yeah, and so sorry to interrupt, William, for sure. And I think, this is bordering on to, something different than what this show's supposed to be, but I appreciate what you're saying, and maybe you putting it out there does help other listeners. So thank you for your call.
And I think of the correlation, what he's saying between mental illness and physical concussion. I think Chris Benoit, and there's some evidence of that back in the WWE.
For sure, yeah, and for sure. And I mean, even when you look at
dementia and everything,
100%. And when you look at like something like his scenario where there's an assault, that can lead to a psychological behavioral issue because now you may be afraid. So yeah, when you're dealing with the brain, we understand so very little about the brain and how everything works that, we're just giving it our best guess right now with where we are in the healthcare world. And does that mean that in 100 years or 20 years that everything will stay consistent and the same things we believe today will be beliefs then? No, things always change. And as our technology, as our knowledge gets better, we'll understand more and more about the way, if there is potentially a link between mental illness and physical trauma to the brain, which, again, your point of, Chris Benoit and the chronic traumatic encephalopathy that they're finding in, football players and things like that, there might very well be a strong link, and we'll find more out as
knowledge
time goes on.
improves.
Knowledge improves.
I don't see a lot of bloodletting in your clinic anymore. It's
exactly.
1600s.
Yeah.
We'll get more of the show, your phone calls as well. 416-870-6400 star 640 on cell. Dr. Payne Show, Talk Radio, AM 640. Good afternoon. How are you? I don't see a name. Who is this? Hello there.
Hello.
Hi.
Hi. Good afternoon.
Hi. I didn't catch your name. What's your name, sir?
Alberto.
Alberto. How are you?
Good. How are you?
Good. What's going on with you?
Just regarding, I work outdoors.
Mm-hmm.
I'm trimming trees, the bushes, stuff like that.
Cool.
And I get a lot of thorns in my skin, and it's just too painful to take out the thorn. And several days it's painful, but once in a while there's still pain. I had a tetanus shot every 10 years. Is it bad to leave thorns or any type of in the skin, especially on the fingers?
Again, it's not really my specialty, but, just as from a professional opinion, I would probably assume that anything that's not supposed to be there is
alien
probably
object
is not a good thing to be kept there for sure. Yeah.
I see.
Do they have non-protective gloves that are suitable for what you do?
Yeah. Sometimes, the thorns goes right to the gloves.
Wow.
And the tip of the thorn stays in the skin.
Painful,
it's very painful to take out. Usually I take it out with a needle,
Yeah.
It's sometimes it just goes right into the deep, and I just don't take it out. But because I have the tetanus shots, I always think, okay, I'm protected, right?
Well, tetanus protects you against potentially getting infected by tetanus. It doesn't protect you from having things from pain, right? So there's two different things there. Are you prevented from potentially getting tetanus? Yes. But are you protected from...
Isn't the tetanus shots due to anything that causes infection? Isn't that why you're taking tetanus shots?
It's specific to the actual tetanus bacteria, so that creates a different constellation of symptoms that can eventually lead to your neurological system seizing up. So it doesn't protect you against every infection. You can still get other infections. It will just protect you against being infected with tetanus.
Oh, I see.
Yeah, so that's two very different things for sure. But from an occupational standpoint, maybe talk to the employer about if there's something better suited that you can be wearing that can protect you. But yeah, anything that's in the body that shouldn't be there is probably
for a prolonged length of time.
Yeah, it's probably not supposed to be there.
416-870-6400 star 640 for you to call. And want to mention something that we went back to with one of the callers a couple segments ago, and that was the reference by said doctor about a room full of useless modalities.
Oh, yeah.
I wasn't a big fan of that comment.
No,
How's the God complex?
Yeah, and you know what? It's unfortunate that people sit out there, and you're right, the God complex for sure. There's certain healthcare professionals that, and again, this is not everybody, but certain people out there, from a patient perspective, I would always be very, very concerned of someone who believes themselves to be the be-all, end-all, and everything else is absolutely useless. Because, it's 2017. We know that it all needs to be multifactorial, multifaceted. People need to work as a team to achieve the best results. And a comment like that is just, at the end of the day, extremely ignorant. right?
Yeah.
Maybe if he's talking about a specific place that he knows that isn't very good, I might understand the comment. But if that's just a general opinion about all places where therapy is done, that it's just a room full of useless modalities, I mean, you can't. The only thing you can say about that's just absolute ignorance, and should speak volumes about that type of person. And if I was a patient, I would definitely be hesitant to be taking too much advice from that person.
And you look at the track record, that patient's 12 months in and still no.
Yeah, I mean, we'll let the facts speak for themselves. If everything else is useless, well, he wasn't much better.
Right?
For 12 months is a long time. So, and again, does that mean, you have to look at everybody and you have to determine there are some things that are going to be more beneficial, that certain tools, and just make the right recommendations. And again, I do truly believe that the best outcomes, and the research supports this, that the best outcomes for most pain syndromes is a multifaceted approach where you're having several different people work on it, just because, again, there's so many ways to intervene and you're tackling it from every angle. So, and it's just ignorance. It's unfortunately the reality of people out there, and there's good doctors, there's bad doctors, the same as there's good mechanics and bad mechanics. And, anybody that's hearing things like that, that's why I suggested to that person, get a second opinion, right? Yeah. Those are the times where you may want to go back to your family doctor and say, can you send me to another specialist that I can talk to, because I wasn't so sure about this comment that was made.
You're well in your rights
whatever.
to do so.
Yeah, for sure.
When we talk about, we've had some emails. I know Jody mentioned something earlier today about mouth pain. It's a topic we really haven't tackled yet, right?
Yes, but I mean, when you look at the jaw, and I guess most people, anytime that there's pain in the mouth, they're just simply going to their dentist, and
right.
And they're using that person as the gatekeeper, which is good. That's the right way to do it. Sometimes, though, we have to take into consideration that jaw pain and TMJ issues can just simply arise from a musculoskeletal perspective, which means that you have muscles and joints in that place the same as you do in your low back, and those things can sometimes get aggravated and need therapy to get them better. Another thing is that jaw pain is very closely related to the mechanics of the neck, of the cervical spine. So it's not uncommon to meet people who have an underlying cervical spine issue that's translating into some type of jaw pain. And most good dentists out there will be able to recognize if it is musculoskeletal, and they'll recommend to go get it treated from a musculoskeletal perspective. But yeah, jaw pain is something that is very, very prevalent, but you don't need to go see your dentist for that. If you have jaw pain and you believe it might be more muscular, a chiropractor, a physiotherapist, a massage therapist, those are all people that could potentially assess that and determine, is there a musculoskeletal component, and here's potentially what could be done to help that issue. But I can't stress enough about the relation of the jaw to the cervical spine, and how the impact of poor posture and an anterior head carriage can really create a lot of jaw issues and tense those muscles. So anybody with jaw issues, or they've been told they have a TMJ syndrome, I believe should also be getting their neck looked at, because it's just so intimately connected that there's often some type of a correlation between the two.
And in that regard, if you have questions about that stuff or any other, we're here to take them for the next 10 minutes or so. 416-870-6400, star 640 on cell. It's info@paincarecanada.com, and simply Dr. Payne online. Check it out. More of the show coming up. Talk Radio, AM 640. Yeah, and if you've sent an email and resend it, we get a lot here, or at least Dr. Lou gets a lot. We'll answer info@paincarecanada.com through email. Got, how's my eyes? I need an eye checkup. Barry, how are you?
Hi, good.
Bet your eyes are better than mine. What's going on, Barry?
I just, about 10 weeks ago, I had my knee done, scoped.
Yep.
For the second time. The first time was about 25 years ago, but I slipped and fell and re-injured it. So I got the MRI, and they said I had a small tear in my ACL, and then the cartilage was all bunged up again. So I went in and got the scoped and surgery, and they cleaned it all out. And when they were in there, they noticed the meniscus had a big tear in it. And now, after that was about 10 weeks ago, say, roughly. and now I got more movement, but I still can't to walk up and down stairs. I still can't bend my knee properly.
Okay.
So it feels like it's locked.
Have you done any? Have they sent you to do therapy after the surgery?
Well, the therapy they wanted to send me to cost money, and I don't have the coverage for it. So I was.
Yeah.
He had a sheet on exercises to do and stuff like that, but he told me to stop doing them for a while.
Right. Yeah, and you know that's
and just keep walking.
Yeah. You know, I'll be very honest. You do need some therapy following surgeries because there's the right things to be doing. There are certain OHIP programs that you can qualify for. Sometimes it depends on who did the surgeon, where you live, the access to that type of care. But, you know, I see this all too often that people who do surgery and don't do therapy after, the outcomes are never going to be the same. You do need to be doing the right type of physical stuff. It's fine if somebody gives you a sheet of paper as long as you're doing the right things day to day. That's also equally fine. But in my experience, most of the time people don't know how to do these things properly. So it may be worthwhile to at the very least spend money one time to get someone to show you the right things to do. And then from that point, hopefully you can take it on from there. Because in the absence of doing those right things, you may unfortunately not get the outcomes that you desire or that should happen after that type of surgery.
Yeah. Okay.
Okay?
Yeah.
Okay.
Sorry, Barry. We had to cut you off there. We're just getting on the last few minutes here. So, yeah, there you go. I didn't know there was OHIP programs you can apply for in that regard. Because a lot of people, 3 people have called today, say they can't afford the therapy.
Yeah, no, for post-surgical stuff, depending, again, where you are, the access to care, these things do change. There are some OHIP-funded things. Whether they're good or they're not good, that's a different conversation. Right. But there are some ways. And again, the access is not as widespread as I'd like for it to be.
Got David, probably a last call of the day. David, you got a couple minutes. What's going on?
Okay, it started out over the years. I drive for a living. I get what we call Charlie horse, like a muscle cramping under the right knee. But I've been able to seem to almost lick it by using mineral water. But recently, I had a fall off my truck, and as soon as I fell, one of the things was my right leg. I felt almost like locked up. And ever since, I've been trying to stretch it, and it's just lingering. It's just like a krampness that just doesn't want to leave.
Okay. Have you had it taken a look at?
Well, I'm currently on what we call a doctor's orders to go on what we call light duty. So I'm still driving, but I'm waiting for my physiotherapy appointment. So I'm just basically stretching it and Advil, and that's where I'm at. It's just lingering right now.
Yeah, I mean, again, you'd have to have it looked at properly. If you're waiting on that physiotherapy appointment, they'll be able to take a better look at it for sure and try to determine what's going on. But in all likelihood, if it's a physical problem, you'll likely need some type of a physical intervention. And there's so many different things that it could be in that area that, I don't even want to start guessing what it could be. But, the biggest things when you have an injury before you have a professional look at it from a management standpoint. If anything that you're doing hurts, you need to avoid that thing that you're doing. That's number one. And then from there, the next step again is try to get in to see somebody as soon as possible, because the longer you leave these things, the more they can become chronic issues, and as they become chronic, they're harder to treat. So that's really the best thing to do. But as a general rule, for people who have sustained something, and before you can get in to see somebody for whatever reason, if it hurts, stop. And it's incredible how many people have hurt themselves somehow and still do the things that bother them. But, that is the first best thing that you could do, is just eliminate that aggravating source, so at the very least you're not making it worse.
Good for another week, brother. Parting ways. You want to get a hold of Dr. Lou? No problem. 1-855-55 Dr. Lou, DRLOU. The email is info@paincarecanada.com. Get that free assessment. Having start on the road to getting better. Getting pain-free. The Dr. Pain Show till next weekend. Talk Radio, AM 640.